interest in gestational diabetes, pregnancy, and diabetes related issues. And I understand that he runs some special clinics and he has many students also working on these areas. So thank you, Yashdeep, for joining us. Over to you for your presentation.
So thanks, Dr. Samir, and thanks, IAP and Dr. Rajiv for giving this opportunity to participate in this ongoing series of lectures focusing on type 1 diabetes. So basically, I have been given a task to share some thoughts on the topic type 1 diabetes and pregnancy. Dr. Samir's slides are visible?
Yes, clearly visible.
So what I will do is basically try to connect means this particular topic to adolescence phase and give you a glimpse of the problems that a woman of type 1 diabetes faces during her reproductive age, and how this particularly early onset issues are linked with the pregnancy and thereafter what we can call menopause period. So my objectives for this particular talk will be to understand the problems faced by a girl or a woman with type 1 diabetes in their reproductive age group. Then go through some of the reasons or like pathophysiological basis for why these problems arise. And then when this problem arise, what could be the further consequences of these issues. And the primary clinical point that we end with is basically, can we do something to help a girl or a woman with type 1 diabetes so that they can prevent these sort of reproductive issues? So with these learning objectives, we move to the problems. So these are the problems actually which are faced by a girl during their adolescence phase, like hypogonadism or pubertal delay, especially when we talk about the periods of 10 to 14 years. Then they have a menstrual dysfunction either at the onset or after having normal puberty. They can have menstrual issues and polycystic PCOS, even in type 1 diabetes. Then near to pregnancy, they can face like issues of reduced fertility or fecundity, and when they are pregnant, they can have pregnancy related complications. And once they're over with their child related issues, so they may have an early menopause. So there is a host of issues that can impact a woman's reproductive period, and the magnitude of problem is too huge. Like even in the Western countries, it's estimated that 40% of the women are impacted by these problems, and the magnitude may be even larger in a means low middle income country where the care is already suboptimal due to reduce availability of resources. So focusing and starting with the initial problems that a girl can face when they enter puberty is the hypogonadism, pubertal delay, delayed puberty, and the menstrual dysfunction. So why they have this sort of problem? Like when they have an insulin deficiency, they actually have a hyperglycemia, and simultaneously, due to utilization of alternate resources of energy like fat and protein, they go into the catabolic state, which results in decreased weight and decreased adipose tissue. And with decreased weight, they have a decreased leptin issues. Leptin is a stimulator of kisspeptin, and kisspeptin is a further stimulator of GnRH secretions. So as a consequence of decreased leptin, they will have a decreased kisspeptin, and which results in a decreased gonadotropin releasing hormone secretion, due to which there is a decrease in LH and FSH secretion. As we all know that these are the important hormones which stimulates ovarian steroid production. So due to their decrease, the ovarian estrogen goes down, which results in hypogonadism, pubertal delay, delayed puberty, and menstrual irregularities. Simultaneously, to decrease leptin pathway, there is a high degree of hyperglycemia in type 1 diabetes, which independent has a toxic effect on GnRH secretion and decreases that. And the third mechanism in insulin deficiency, insulin per se is a stimulator of kisspeptin and GnRH secretion. So if there is an insulin deficiency, there is a paucity of insulin stimulating the insulin receptors in the brain, which can also decrease the GnRH secretion. So there is a multi-path issues which are there, which results in these sort of problems, even at early as close to as 10 years of age, which we can recognize. So this is a So this is a graph which shows that matlab, the onset of menarche in relation to the age of onset of diabetes. So as we can see, if there is a diabetes which is early onset, the menarche is late. So obviously there is a toxic impact of hyperglycemia during early years in the reproductive age span and starting from menarche itself. So as the age of onset increases, the menarche occurs near to normal period, and when it's like after the prepubertal, obviously the most of the women will have their normal menarche. So there is a clear cut relation in the early onset of type 1 diabetes and the onset of menarche, which is seen in the larger studies. When we come to the absolute number of figures, to just have an idea ki what's a magnitude of delay that we can see with the type 1 diabetes when they have an onset before puberty or when they have an onset after the pubertal period, like more than 10 years. So it has been seen that if the normal controls in a particular group has a age at menarche 11.9 years, the type 1 diabetes which have age of onset more than 10 years, they will have a menarche at 12.3 years. And if they have an age of onset less than 10 years, there is a further delay in the onset of menarche. This is another slide to just an idea like how we correlate with the degree of control, glycemic control, and the menstrual abnormalities. So this is a one good study which helps in understanding like what sort of impact we can see with the different degrees of hyperglycemia. So menstrual cycle duration, if we see that control if it has a 32 days mean menstrual cycles, and type 1 diabetes who are having A1C less than 7.6 is still near to that 32 figure. So there is no much impact if the glycemia control is optimal, as defined by 7.6 in this particular study. But as we move towards the insufficient or poor control, which is defined by like 7.6 to 8.9, there is a marked increase in the menstrual delays. So mean cycle length is 48.6 years as compared to 34.9 in this category. And when we talk about the greater than 9, that is a poor glycemic control, it's nearly double as compared to the control. So there's a marked impact on menstrual lengths with the degree of hyperglycemia. Similarly, we talk about amenorrhea, which is defined as a 90 days period of no menses. So if it is like 1.8% women impacted, girls impacted by this sort of figures in control arm. So less than 7.6 is nearly close to that control. But as we move to the insufficient or poor control, the degree of amenorrhea also increases, which again shows that poor glycemic control is associated with menstrual irregularities. And as the A1C worsens, there is a marked increase in the menstrual issues. This another point shows that regression analysis that for each point of increase in A1C, the menstrual cycle duration increased by 5.1 days. So we discussed like there is a impact of hyperglycemia, there is an impact of duration of diabetes on the age at menarche. It's also crucial to understand like what are the consequences if the menarche is late. So this is a Finnish type 1 diabetes study called the FINDINE study, which showed that if the menarche is delayed by more than 2 years, the rates of diabetic retinopathy is nearly 2.3 fold compared to those who have a menarche within plus minus 2 years of mean age. So there is a 2.34 odds of diabetic retinopathy, and the diabetic nephropathy has a 2.3 odds of diabetic nephropathy. And these are like severe complications as defined by macroalbuminuria or end-stage renal disease, which they called as diabetic nephropathy, and laser photocoagulation as severe retinopathy. So obviously it is a linked with the sort of dire consequences in type 1 diabetes. Either it's just a coexistent, like if some it's impacting the menarche, the hyperglycemia is also associated with diabetic retinopathy, no, nephropathy is a coincidence associations, or there is actually a causal relationship between the two, that is not clear. But one thing is clear, that if patient is having a delayed menarche, though they are at high risk of developing complications. So moving from pubertal period to the post-pubertal period, when when a girl actually has that normal menstrual cycles, even type 1 diabetes is associated with the menstrual dysfunction and polycystic ovarian morphology and hyperandrogenic traits after puberty. So this is a systematic review which is compiled from 9 primary studies involving 475 adolescents or adult women. And it shows that polycystic ovary syndrome is fairly common in type 1 diabetes. The frequency being 24% in this meta-analysis. Hyperandrogenemia means increased hair growth. Clinical biochemical hyperandrogenemia, that is common in 25%, means 1 in 4. Similarly, clinical hyperandrogenemia in the form of hirsutism is also seen in 1 in 4 girls or the women. Menstrual dysfunction 1 in 4, and the polycystic morphology 33%. So nearly 1 out of 4 is definitely impacted by these menstrual issues even after the completion of puberty. So what are the mechanisms which results in polycystic ovary syndrome? So hyperinsulinemia impacts uh, through multiple pathways and results in this sort of manifestation. Insulin, as we discussed previously, is required for stimulation of GnRH. Obviously, if insulin levels are more, the stimulation of GnRH, gonadotrophin releasing hormones, will be more. So increased pituitary responsiveness to GnRH will give rise to increased LH predominantly. And hyperinsulinemia is also stimulates the IGF-1 receptors and the insulin receptors that are present in the granulosa cells, thecal cells, or stroma cells of ovary, and result in androgen, estrogen, and progesterone production, independent of LH and FSH. So through increasing the LH and FSH and independent of LH FSH by acting at the ovaries, it results in increased androgen production, which can result in hyperandrogenemia. And it also stimulates the stromal proliferation, resulting in enlarged ovaries. It also results in proliferation of smaller follicles, which looks like polycystic ovaries, but prevents the recruitment of smaller follicles into a larger follicle, means for ovulation, resulting in an ovulation. So through multiple mechanisms, hyperinsulinemia can results in polycystic ovary syndrome and hyperandrogenemia. In type 1 diabetes, the hyperinsulinemia in type 2 diabetes is predominantly due to insulin resistance. In type 1 diabetes, what happens? We give subcutaneous insulin administration, which bypasses hepatic first pass clearance. So the ovaries are exposed to high concentration of exogenous insulin. So prolonged exposure of ovaries to increase insulin again results through similar mechanisms, polycystic ovary morphology, and increased ovarian androgen production. Though the androgen production may not be as severe as in the type 2 diabetes phenotype, but still the patient can manifest polycystic ovary morphology and hyperandrogenic traits due to the high insulin exposure required for the management of hyperglycemia. So what are the clinical implications? Obviously, if there is some problem, we have to judge what could be the clinical consequences for that particular problem. So I'm not sure like what number of girls will come to the pediatrics due to the irregular menstrual cycles, but this is very common in the adult endocrinology. And they have a lot of psychological issues due to the concerns of irregular cycles, because there is no predictability and they are always concerned. Again, it is associated with the reduced fertility, and which subsequently more of women requires assisted reproductive techniques for conception later on. And PCOS in general is associated with increased cardiovascular risk and requires regular monitoring of cardiovascular risk factors on an annual basis. So obviously a PCOS has certain implication in the reproductive age group, psychological issues, and cardiovascular issues. And prevention therefore can decrease these sort of clinical implications. So from this phase of polycystic ovary morphology, which like typically we can see from onset of menarche till the patient plans pregnancy, then there is a phase where the women gets married and starts thinking about conception or the fertility. So even the type 1 diabetes is associated with the reduced fertility and chances of conception, which called fecundity. So what is the data regarding that? What we have an understanding regarding the fertility in type 1 diabetes. So this is a last study from Sweden, which shows that the observed rates of live births compared to the expected rates of live births in the general population are low in type 1 diabetes. So there is a 20% decrease fertility rates compared to the general population in overall population women of type 1 with type 1 diabetes. But if there are complications like nephropathy, retinopathy, neuropathy, the odds of fertility goes further down. Like dramatically, there is a half chances of having fertility compared to the other women without type 1 diabetes with along with this complication. And if there is a macrovascular complication, it's nearly one third. So obviously there is a marked impact on fertility rates in type 1 diabetes during the phase when they plan pregnancy. Then this is a study which suggests that rates of having conception, the possibility of conception in a particular menstrual cycle. So odds of conception in within a particular menstrual cycle is what has been defined as a fecundability. So it's like 24% decrease rates of conception compared to the normal population in type 1 diabetes. So there is a again means impact of having conceiving a child. If we translate data into the clinical indicators, what is called the time to pregnancy of more than 12 months, it is like when the women starts planning pregnancy and they are having unprotected intercourse. So even after that adequate intercourse, the time to pregnancy of more than 12 months is like seen in 20% of women with type 1 diabetes compared to the control figures of 11.2%. And most of the women then have to seek infertility treatment for undergoing pregnancy, which is like nearly two times compared to control arm, which is 15.4% in seven compared to 7%. So obviously they have implications on resources when they have to spend means there are psychological issues of having delayed conception, and then there will be increased expenditure for seeking treatment for having pregnancies if they are not having spontaneous one. So once the women conceive, there are associated with pregnancy complication type 1 and type 1 diabetes. So this is a data which is like very well quoted in literature. This is like 5 year national population based audit of a UK population from 2014 to 2018, which gives insight like what sort of problem pregnant women with type 1 diabetes faces. So this is a population in which there are even increased utilization of resources. When we say increased utilization of resources means the best of the analogs means are most of the women in this population uses the analog. Then there is a provision of continuous glucose monitoring system. Some women may be on insulin pumps. So with marked availability of resources, even the outcomes are poor, which we can see in this particular slide. The upper graph shows that the rate of congenital anomalies, these middle rates, the blue bars are type 1 diabetes. As you can see, like with the increase in A1C, there is an increased rates of congenital malformation. So in general, the rates of congenital malformation in type 1 diabetes is 10 times compared to the normal population. And the rate of perinatal death in the lower half of the graph, this is nearly 5 times compared to the general population. But even within a population of type 1 diabetes, if the A1C is more than 9%, there's a marked increase in congenital malformation. And even the perinatal mortality increases markedly. So it's desirable that the women who conceive has a good A1C control, preferably around 6.1% or not more than 7%. With the increasing A1C, there will be a risk for congenital malformation and perinatal deaths among many of the complications that can seen with the type 1 diabetes, which in clinical terms helps in understanding that tighter the glycemic control, lesser the magnitude of complications that can be seen in type 1 diabetes during pregnancy. This is another subset of complications apart from congenital malformations and perinatal deaths. So even the preterm delivery is less than 37 weeks. This is markedly high, 42.5%, which was seen in this population. Then LGA babies, 52.2%, and NICU admissions, nearly 4 out of the 10 neonates born to the type 1 diabetes requires NICU admissions. So there is a great amount of resources that are then utilized to tackle the complications of type 1 diabetes, both for the mother and for the baby. Having understood the problems that can a woman with type 1 diabetes can face or have that pregnancy complications, the clinical counterpart then comes how we can reduce these pregnancy complications. So there are two components. One is a preconception care, and second one is obviously a care during the antenatal period when they actually are pregnant. So it has been shown that preconception care for diabetic women can help in improving the maternal and the fetal outcomes. So this is a systematic review and meta-analysis which suggests that relative risk of congenital malformations, preterm delivery, perinatal mortality, they all decreases markedly when the patient is under preconception care. And when we talk about preconception care, it matlab, as per literature, it should ideally start once the patient enters the reproductive age group. That is the onset of menarche. So it should be a periodic ongoing educational modules where the girls or the women should be sensitized that they should have good glycemic control, and before planning pregnancies they should seek the preconception care more religiously, so that the complications during pregnancies can be decreased. So the women who seeks preconception care, they have a better glycemic control. It has been shown that nearly minus 2.4% good glycemic control as compared to the women who doesn't seek preconception care, and they report early in the pregnancies given more chances to optimize the pregnancy outcomes early during the antenatal period. So what are the goals of preconception care when we say that the preconception care is an ideal? So one, if the purpose is to increase the intake of folic acid, because if the women is not on folic acid, the chances of congenital malformation increases. Then the women could be potentially on teratogenic drugs like ACE inhibitors or angiotensin receptor 2 blockers for diabetic nephropathy. So there could be some potential such drugs which are ongoing, which has to be stopped. That is one goal of the preconception care. Then most of the women who have a onset of diabetes like more than 5 to 10 years especially may harbor some sort of complication like retinopathy and nephropathy. So both these complications can worsen during pregnancies, and it is important to fix this complication, like whatever the treatment is required to work up for that sort of things and fix that before patient undergoes pregnancies. Then obviously the cardiometabolic goals are there, the optimization of A1C less than 6.5% preferably, manage weight, manage blood pressure, and if required, lipids also. And then the patient has to be educated for some practical issues like insulin related issues, which we will discuss in subsequent slides. So it involves like crucial elements of fixing something and providing certain drugs, means changing the portfolio of drugs so that are potentially safe and beneficial, then cardiometabolic, and then education. These are the three broad domains under which the preconception care has to be provided. Now, what could be the impact of diabetes duration on attainment of target glycemic control? When we talk about less than 6.5% glycemic control in the periconceptional period, it has been seen that the women who has a longer diabetes duration has a more difficulty in attaining this sort of goal. So this means that we need to put more effort, especially in women who have a onset of diabetes in the younger age group, so that they can have healthy pregnancies. Similarly, we also have to focus on the weight during the preconception period, which we can say from a menarche till the planning of pregnancy. So the weight should be less than 25, because as the weight increases above 25 BMI category, the risk of attaining glycemic control decreases, which will have subsequent impact as we had seen previously in certain slides. So this is a general slide in insulin, means it's not like limited to pregnancies. It's a general dictum sort of stuff which we have to do routinely in day-to-day care practice. In education, when we talk about education, we have to teach a patient the insulin technique so that they take right insulin in a right manner. We have to teach them like how to prevent hypoglycemia, and if hypoglycemia happens, how to take care of that. Then it is good like to how to maintain a particular log so that we can adjust insulin accordingly. And if possible, the patients are intelligent enough, it is wise to teach them dose adjustment so that they not have to depend only every 3 months or visits to a doctor for dose adjustments. So education part is very critical in insulin means management of type 1 diabetes, and along with that is a sick day rules to prevent diabetic ketoacidosis. For pregnancy per se, means it's important that whatever the insulin we will prefer during pregnancy, So that insulin regimen is started beforehand, preferably 3 to 6 months before planning pregnancy. So either conventional or analogs, whatever we think that will be better suited during the pregnancy time, it is better to switch beforehand. And whatever regimen we prefer to give during pregnancy, it is better, because in like routine practice, even in at AIMS, we prefer like giving basal bolus during pregnancy, but most of the patient preconception due to convenience may be on split mix regimen or lesser number of insulin injections. So it is important to transition them from split mix or limited number of injections to standard basal bolus regimen, so that whatever the adjustments on that particular regimen has to be done are done at a right stage rather than during pregnancy. So this is again a marker of preconception care from that same UK studies, which shows that even in the best of the world, that seeking preconception care is suboptimal. Like even the women is aware that they have type 1 diabetes, even they are in continuous touch with the physician, even there are like specialized clinics for preconception care, still seeking preconception care is very, very poor. So it has been seen that in that study that only 44% of the women were for taking folic acid before conception. So there were like certain amount of ladies which were on unsafe, potentially unsafe drugs at the time of conception, and there is a first trimester A1C was on a higher side. The A1C goal of less than 6.5% was achieved only 1 out of 6 ladies, which shows that even in the best of this scenario where the resources are available, the optimization is very, very poor. So what could be the reasons for poor preconception care? There could be two main domains. One, patient-related barriers. Well, they are not aware that they have to seek preconception care. This means that at the right stage, we have not provided them education enough that they have that knowledge of preconception care. And either they are too busy in their schedule that they are not able to take time for periodic visits to the doctors. So this sort of sensitization, I think, should happen periodically again at from the start of diagnosis and at periodic intervals, that the women should be aware like what has to be done at what stage, and they continue to seek care for their type 1 diabetes, and it has health has to be prioritized even in the difficult sort of circumstances. Then there is another domain called the clinician related issues, that clinicians may have insufficient knowledge that they have to provide preconception care. Then what are the elements of preconception care, what is the right stage for initiating preconception care. They may have time constraints themselves to get into that sort of conversation for preconception care. There may be a discomfort at discussing pregnancy and contraception. So there could be some clinician related issue and women related barriers which we have to overcome, so that the preconception care is optimized before a woman undergo pregnancy, and that should start at the age of menarche itself. Now the question comes how we can reduce the pregnancy complication, that is care during pregnancy. So these are the A1C targets. They are very tight compared to in the preconception or in general non-pregnant ladies. So preconception, preferably it should be less than 6.5%, first trimester less than 6.5%, then second and third trimester less than 6%. So they are very actually very, very tight as compared to the non-pregnant women. So this is a difference in glycemic targets. So again, women has to sensitize that what they are keeping blood glucose values in a non-pregnant state are not same in the pregnancy. So that sort of awareness also should happen at the preconception period. So concept trial is the largest trial done in the Western countries, advanced economies, where again the women had analogs, CGMS use full pregnancy, and then insulin pumps in most of the patients. So that despite that all resources, the first trimester goal of 6.5% was achieved only in 23.5%, second trimester 27.9%, and third trimester 3.8%. So despite of the resources, it is very, very suboptimal, which shows that pregnancy itself is a challenging period. So any education, any optimization should be done beforehand, so patient goes prepared during the pregnancy, in the pregnancy. Then there are Apart from self-monitoring blood glucose, there are CGMs, which is now used in the care of type 1 diabetes, especially in pregnancy. So these are the targets, what we call the target range, 63 to 140. More than 70% of the time should be within this target range. And the hypoglycemia, they should spend less than 4% time. And above 140, they should be less than 25% time. So main thing is that we have to keep women in the target range of 63 to 140 for more than 70% of their time during the day. But even that targets are very suboptimally achieved. This is again the same concept trial where CGMS was used during whole pregnancy. The first trimester, only 7.7% women achieved that sort of target, more than 70% in 63 to 140 range. In second trimester, slightly improved figures, 10.2%, but again 90% were not in that time in range. In third trimester, the relatively more number of women achieve this sort of target, but still 65% are not in that sort of things. And that third trimester is too late to afford like maximum benefit for the mother and the neonate to reduce complications. This is again slight despite that of intervention, means in the concept trial, like usual care, you see that 24.1%, in intervention 23% A1C goal, 24 weeks 25.5%, 30.5%. Only at 34 weeks there is a little appreciable difference between the control arm and the intervention arm, again reinforcing that if any intervention has to be started, if anything has to be started, it has to be started before pregnancies, so that that sort of difference are not too late to be achieved during pregnancy. From observation of SMBG value, then comes the management diet plan. Again, it is a similar sort of diet plan which we advise a person with type 1 diabetes in a non-pregnant state that they should take three main meals and three minor snacks, so that the postprandial excursions could be decreased and the tendency of hypoglycemia when they're not taking snacks could be decreased. So 3+3 diet pattern, which is adopted in the non-pregnant state, is also advised during the pregnant state. But one should not only focus on glycemia part. Again, this is a slide which is particularly focused on during the pregnancy, but it again has some messages in the non-pregnant state also. So euglycemia obviously is a main goal of diet, but it is not only the sole goal for diet modification. The diet, whatever is advocated, should be nutritious. So we have to check like what patient is taking, even the patient if is having euglycemia. And then patient should be satisfied with the diet pattern. There could be like scenarios where we advocate diet which culturally is not appropriate. So patient may take for a week, 2 weeks, months, or some months, but gradually will shift back to that sort of their own cultural diet. So the patient should be satisfied with the diet also for long-term sustainability of diet advice. Then in pregnancy, there are additional parameters where we need to keep in mind, just like the gestational weight gain, what is happening during pregnancy or particularly during a week, how the fetal is responding to that nutrition, means monitoring fetal growth. So these are additional parameters. And even like weight gain or weight loss could be additional parameters in the non-pregnant state. So if someone is gaining weight unnecessarily, then it may be indicating that diet is not correct. In pregnancy per se for diet, there is a dictum that it should not be less than 1600 kilocalories, not less than 45% carbs, not less than 175 gram of carb. And the reason for behind this stat is that minimum amount of carb is required in pregnancy so that there is no ketone formation, and because ketone formation can result in neurological issues for a child. So to prevent ketosis and subsequent its impact on neuro developmental of a child, so it has to be minimum carb has to be given, but high glycemic index carbs has to be avoided even during the pregnancy. Coming from diet, exercise is a standard. Whatever the exercise advice we usually give during non-pregnant state, it's practically the same in the pregnancy for type 1 diabetes. So coming to the management, insulin is the sole pharmacological agent that is used for management of hyperglycemia, and the basal bolus regimen is a preferred regimen during type 1 diabetes. So Lispro and SPART analogs are approved during pregnancies, and we have level 1 evidence, what we call the evidence from randomized control trials for Lispro and SPART to be used in pregnancy. We don't have any evidence for glulicin, so patient should be taken off glulicin with near to the pregnancy period. And detimid decoludec are the long-acting analogs which are approved and have a level 1 evidence for them. Glargine can be used in pregnancy, but we don't have any RCT for glargine during pregnancy period. What we need to understand that analogs has a lesser tendency for hypoglycemia, decreases glycemic variability. But despite that, there is a similar level of A1C that has been seen in the women taking analogs versus conventional insulin. The rates of hypoglycemia are same, pregnancy outcomes are same. So we can say that these analogs are safe to be used during pregnancies and can be used on case-to-case basis, but it is not like absolute necessity to use this drugs if the patient is not affordable. Then I showed data regarding CGMS from the concept trial. The what additional focus that is now currently in pregnancy is the use of hybrid closed loop insulin delivery systems in type 1 diabetes. So what are the advantage of hybrid closed loop? Means there is a CGMS sensor which is linked to the pump. So this linkage can help in sort of management in 4 particular domains. One, like sensor gives a value which is low, the pump will stop. The sensor continuously gives the value. There is a predictive logarithm. So the sense it will sense that, okay, we are going down towards a low and there could be a potential hypoglycemia. The pump will stop. Then there are advanced pump models in the hybrid closed like depending upon the what is the glucose prevailing, there will be automatic adjustment of basal insulin rates. And some more advanced pumps will even give small boluses to immediately correct the hyperglycemia. So this is how the hybrid closed loop insulin delivery systems are being planned, and they are increasingly used in trial mode currently for type 1 diabetes and pregnancy. So the advantage is that when there is an automatic system of stopping the pump or predicting hypoglycemia and decreasing the rates or stopping the insulin flow, so there are low risk of severe hypoglycemia and less fear of nocturnal hypoglycemia, which translates into a better sleep quality. There will be lesser glycemic variability. Patient will be able to spend more time in range, and as the time in range increases, every 5% increase in time in range will decrease the complications associated with type 1 diabetes and pregnancy. But the disadvantage of hybrid closed loop system in pregnancy is that pregnancy is a dynamic state. The requirements of insulin will keep changing as the pregnancy progresses. So the fixed algorithm may not work well during the pregnant state, especially as they move down the line in terms of period of gestation. And there could be like as they spent time closer to the normal, there will be like repeated alarm signals due to hypoglycemia. There could be like such sort of alarm fatigue and technical issues that can come. So it's still in the trial mode. We still don't have adequate data to support that hybrid closed loop system will be better in type 1 diabetes, but this is what is currently in process. Now, when we try to keep glucose in a tighter control, there will be risk of hypoglycemia. It is particularly severe within the first 16 weeks of gestation. Because and the risk factors are that if patient is having history of severe hypoglycemia within the past years, impaired hypoglycemic awareness, longer diabetes duration. So these are the risk factors for hypoglycemia during first 16 weeks of gestation. Again, the measures, insulin analogs, CGMS, and insulin pumps has been shown that they decreases the rates of hypoglycemia in initial first 16 weeks when there is increased sensitivity. And we have to reduce the dose of 10 to 20% at 8 to 16 weeks period of gestation to prevent hypoglycemia. Apart from hypoglycemia, apart from hyperglycemia due to type 1 diabetes per se, there are other players which can make or increase the pregnancy complications worse. One is a glycemic variability. Pulsatile glucose again can result in fetal hyperinsulinemia, resulting in excess fetal growth. If it is a maternal obesity, it again can increase the amino acids, which can stimulate fetal growth. Then maternal lipid levels coming from the diet, again this can stimulate fetal growth. And excessive gestational weight gain again can stimulate fetal growth. So these all factors has to be taken care of if we want an optimal pregnancy outcomes. So the management strategies that control hyperglycemia, keep it less than 6.5%, reduce the glycemic variability, uh, help in tackling the maternal obesity before conception. That is, women should ideally have BMI less than 25 kg per meter square, then optimizing the gestational weight gain during pregnancy and modifying the diet so that the lipid levels are not raised during pregnancies to reduce these sort of complications. Coming to another complication set, diabetic ketoacidosis, there is a difference as compared to the non-pregnant state. It can impact 0.5 to 10% of the pregnancies. There is high risk of fetal morbidity and mortality. The difference it is that diabetic ketoacidosis in pregnant state can develop more rapidly and at less severe hyperglycemia and even with normoglycemia. So if there are any warning symptoms, patient has to check the ketones, and if ketones are positive, has to check the PA so that we can detect decay at the earliest. And patient should need to be aware of this decay, prevention of decay, and education should be full for this, preventing this sort of complication. Diabetic retinopathy, again, when we screen women for type 1 diabetes, 1 out of 2 women will have any diabetic retinopathy in the early pregnancy. Even the women doesn't have any diabetic retinopathy, 15 out of 100 women will develop new onset diabetic retinopathy. So there is a worsening of NPDR. 31 out of 100 women with the NPDR will worsen. There will be progression from NPDR to PDR in 6 out of 100 women with PDR. And there could be a worsening of PDR, which again indicates that there is a tendency for worsening of diabetic retinopathy during pregnancy. So if it is like a severe NPDR or PDR, it has to be tackled before pregnancy. And again, in a preconception, means in a period before pregnancy, that glycemic control should be optimal, so that actually the women should not have any diabetic retinopathy when she conceives, so that the pregnancy doesn't put additional pressure on that sort of complications. If there is a nephropathy, diabetic nephropathy, it increases the complication. As you can see in the graph, like there is a 11-fold higher odds of preeclampsia when diabetic nephropathy is present. There is a higher odds of preterm delivery, higher odds of congenital malformation, perinatal deaths, NICU admission. So any complication will just increase the complication rates, which are already there high in type 1 diabetic patients. So psychological issues, pregnancy again is a state of heightened anxiety. There is a significant impairment of psychological health. Patient will have some sort of pressure in maintaining the blood glucose targets, and they feel that there is a difficult interaction with healthcare professionals. So it is better to have means a professional attitude, providing more like support and empathetic engagement with the healthcare team, which can reduce this sort of psychological issues. And this even are important in the non-pregnant state. Coming to a couple of 3 or 4 last slides to wrap this presentation. This is just to show that in labor is a period of stress, that any period of stress, your monitoring will increase like 30 minutes to 1 hour or 2 hours. Your glycemic control will become tightened. And in this particular case, if the pregnancy, when they deliver, the rates of insulin doses will dramatically decrease in the postpartum period, and the targets are little relaxed as compared to the pregnant period. Breastfeeding, there is a protective effect on child. Usually there is a misconception that if they feed, the chances of type 1 diabetes will increase in the fetus, but it is not so. If there is a lower rates of breastfeeding, the child will have more complications, and so will be the mother. So it is better to promote breastfeeding. Insulin requirements are less during breastfeeding phase, and drugs which are unsafe during pregnancies are also avoided during lactation. So one slide on menopause. If there is a glucotoxicity, there is a normal ovarian folliculogenesis, there is follicular apoptosis, and the women can have early menopause, which has implications for osteoporosis and cardiovascular health. Last 2 slides on offspring also. What is the risk of type 1 diabetes in offspring if a mother is having type 1 diabetes during pregnancy? So it is very, very low. If like we have 100 pregnancies in type 1 diabetes patients, so only 1 to 4 offspring will develop type 1 diabetes subsequently, which are very low compared to what when their fathers actually have type 1 diabetes. And pregnancy per se is associated with overweight among offspring. Like if women is having type 1 diabetes, hyperglycemia will result in certain epigenetic changes, and these childs are more prone to develop cardiovascular complications. So it is important to promote health at a family level when we tackle type 1 diabetes in pregnancy and after that. So summarizing my presentation, what I try to highlight, there is a number of reproductive problems. Means some will manifest even during the adolescent phase when the childs are practically following up in the pediatric clinics. The prevalence is quite high, so we need to keep a watch on these sort of reproductive problems. there is a association with high degree of glycemia and diabetes related complication with this sort of problem. So we have to manage glycemia at our best and prevent diabetes related complication to reduce the issues related to reproductive period. Then when these problems manifest, they have their own adverse consequences. Like I showed that delayed menarche is associated with diabetes related complication, pregnancy I showed. So there is again adverse consequences for these sort of issues. And this could be a marker of high risk phenotypes, like menarche could be a marker that this patient can go and develop diabetes related complications. So once we see these sort of red flag signs, we need to keep a more vigilant, we need to be very vigilant in the follow-up of patients so that they have a best glycemic control. And awareness for certain issues are required from both for the patients and the provider. So thank you so much for your kind attention and patience in hearing this
Thank you,
presentation.
Yashdeep. I think you had nicely touched the various aspects where a type 1 diabetic patient can have issues, whether with regards to menarchal issues, pubertal issues, pregnancy related issues. Very rightly presented. Couple of questions from my side, Yashdeep. I think there are just one question at the moment from the audience. What about contraception advice with regards to type 1 diabetic, Yashdeep? These are a couple of things which I have been put by my type 1 diabetic patients in my clinic.
So we have lesser number of studies on contraception in context to diabetes. There are two concerns. One, whether it will worsen the glycemia, and second is whether it will be associated with more cardiovascular complications. But the data is not too strong to suggest any particular one sort of contraception benefit over the other. But obviously, we have to keep the side effects of any particular contraception and the profile. For example, someone using a contraception which has a tendency to increase blood pressure or lipids. So a women who is already having type 1 diabetes, nephropathy, hypertension can be exposed to more complications after using this particular sort of contraception. I think this sort of side effect profile for contraception and the profile of a woman has to be kept in mind. But in general, there is less data to guide or say that this particular one is better than the other.
Okay. Even if the patient has hypertriglyceridemia, I think that is also one of the some issues with regards to use of OCPs.
Yeah, the main thing is that thromboembolic episodes, means the tendency for thromboembolism, that is concern for OCPs, and certain estrogens are also associated with hypertension. So I think that there will be some issues. But again,
So progesterone only or intrauterine devices will be preferred.
yeah, and the thing is that especially in the interconception period, that is important to use a safer contraception so that they don't get like unplanned pregnancy, which has more marked consequences as compared to the
Okay.
effects of contraception per se.
So recently, Yashdeep, I had one type 1 diabetes patient who conceived, but she was having a lot of hyperemesis. So it became really challengeful for controlling of blood glucose and titration of insulin doses. So, what is your experience with regard to this? Because initial for 8 to 12 weeks, many of these have hyperemesis because of pregnancy.
So I think at this stage, like initial 6 months, there is nearly 5 times risk of hypoglycemia as compared to the hypoglycemia in the preceding phase. And obviously, there is a hyperemesis, the chances of hypoglycemia further increases. So in this phase, in this particular domain, it is best to use the insulin analogs, which are like shorter acting, right? And if there is a flexibility or resources available, even that insulin pumps are quite helpful so that we can titrate doses accordingly. But at least insulin analogs will be the ones which can be used during this period, which gives you more flexibility and lesser tendency of hypoglycemia at this stage. And
Okay.
targets, if like hypoglycemia is troublesome, so either the says that it A1C should be less than 6.5 or 6, but if there is hypoglycemia is troublesome, one can like go for a higher A1C like 7 to 7.5 even at this phase if it is like highly troublesome.
So we usually ask Dr. Yashdeep for 6 times profile. Nowadays, I am encountered by patients who are asking for Libre Pro and others these sensors. So first question is, are they reliable? And second is, uh, what is your practical experience for this?
So CGMS, there are two different versions available. One is a professional Freestyle Libre, which is available, and then there is a Freestyle Libre 2, which is available in the market called the patient version. So I think Freestyle Pro Libre Pro is not as good to be used in pregnancy because it's just you can like it is a cheaper as compared to the Freestyle Libre 2, but it is not too reliable. But Freestyle Libre 2 still is a reliable, which can give you like time in range, which I showed it like one of the slide, 63 to 140. So this gives additional glycemic metrics to follow. So in Western countries like UK and Canada, they have advocated that CGMS should be used throughout the pregnancy for type 1 diabetes. So these are, I think, reliable one, especially the advanced versions. And it also gives you like idea like what meal
And still we go for finger pricks also simultaneously.
finger pricks has to be done simultaneously. So these are additional, not cannot be solely
And
reliable.
that can help in matching the readings also.
Yeah. The second
Okay.
thing,
And simultaneously finger pricks, they can help in matching the readings
the one thing is that initial period of
if
six
these are accurate or not.
initial 16 weeks there is a high risk of hypoglycemia. So sensors are not reliable when the values goes less than 80 milligram. So they could give foul signals which can inappropriately help in reducing the dose. So it has to be like when use has to be tackled meticulously also.
And most of them are using their app based from their mobile phones. So I think that is just a surrogate for the reader.
Yeah.
Okay. Uh, Another, I think one question, we just have one question from the attendee. Does the risk of neonatal PPHN, I think PPHN, the attendee, what I understand is persistent pulmonary artery hypertension. That increase if mother had GDM with poor control or overt diabetes. Any data and any comments on this?
No, I am not sure on this particular complication because mostly we talk about the respiratory distress syndrome, neonatal hypoglycemia, hyperbilirubinemia. It may be associated, but I am not aware. If it is here, it may not be so
I
common.
think there was one. Yeah, I don't think we have much studies. There was some evidence from the observational studies. This was published in Canadian Journal of Diabetes many years back. There was some association of poorly controlled diabetes with association of persistent pulmonary artery hypertension. Maybe because of this decreased production of NO, nitric oxide, because of poor glycemia. There has been some other risk factors, I think, which have been associated with persistent pulmonary hypertension, like birth asphyxia, delivery before 37 or after 41 weeks. But particularly with regards to poorly controlled diabetes, what I understand is this can be the one of the pathophysiologies that poor glucose levels, high glucose levels, inhibiting the endothelial nitric oxide. So, except for few observational studies, we don't have much data with regards to this. Uh, I think we don't have any more questions, and we have close to 50 attendees at the moment. And I think it was a very crisp and eye-opening presentation, at least for me. Dr. Yashdeep had touched many practical points, and there are a lot of things to be discussed. We can go on, and still many areas are there. Targets, glucose control with insulin. What about metformin and pregnancy? A lot of things, I think, for gestational diabetes. But Dr. Yashdeep has nicely touched on many aspects today. Thank you all for joining, and thanks, Dr. Yashdeep, for your beautiful presentation. Thank you.
Thanks, Dr. Samir. And thanks for all those.
Thank you.
Thanks for attending.
Thank you, IAP. Thanks to Rajiv also, who has been quite instrumental, I think, in designing various courses and designing this program in association with IAP. Thank you, Raj.